Good afternoon, everyone. My name is Maria Sedeno, and on behalf of Respi Plus, it is my pleasure to moderate today's webinar. I'd like to welcome you to this new webinar of our Expand Courses online training platform. Today's presentation, Symptoms Management in COPD, will be presented by Alexandre Joubert. This webinar is sponsored by GlaxoSmithKline, and we are very pleased to be able to offer this continuing education opportunity. Just a few housekeeping items. This webinar is being recorded. If you are joining us by phone, please note that your phone lines will be muted during the session. We will ask that any questions be typed via the question and answers feature of the webinar software. We will do our best to answer all your questions at the end of the webinar. Alexandre Joubert is a case manager at the COPD Clinic and Pulmonary Rehabilitation at the Montreal Chest Institute. After graduating from McGill University with a Bachelor of Science in Nursing in 1995, Alexandre Joubert started his career at the Montreal Chest Institute on the acute and long-term care units. In 1996, he started working at the ambulatory services in different programs. Since 2001, he has been permanently working as a case manager in the COPD Clinic and Pulmonary Rehabilitation Program, educating patients to self-manage their chronic respiratory disease. And with that, I would like to welcome Alexandre Joubert and invite him to begin his presentation.
Thank you very much, Maria. So it's a pleasure for me to present today's webinar entitled Symptom Management in COPD. So to start off, I'd like to mention that I have no disclosures to make for this presentation. And this webinar was developed by an initiative of Respi Plus, which is a nonprofit organization, and it's been made possible through an unrestricted educational grant from JSK. So here are the two objectives of today's webinar. First of all, we're going to discuss the different challenges faced by healthcare professionals when supporting COPD patients in dealing with their symptoms. And then we're going to explore proven strategies to improve symptom management, as well as how to improve the success of these interventions. So in order to reach these two objectives, this is how the presentation is organized today. So we have three sections. First of all, we're going to briefly discuss the impact of COPD, and then we'll get to our two objectives. So section 2, we'll talk about improving symptom management. And finally, in section 3, we'll talk about successful interventions. So let's start with the first section, the impact of COPD. So what is COPD? So as you know, so it's chronic obstructive pulmonary disease. It's a common and preventable and treatable disease. And being chronic, it's progressive, usually over time. It's characterized by persistent respiratory symptoms. And in one of the next slides, we'll describe a bit more in detail these symptoms. It's also characterized by airflow limitation, which is not fully reversible. And that can be a difference with asthma, where the airflow limitation can be fully reversible, but it's not the case. So it can be partially reversible in COPD, but not fully. And also, it's usually caused by significant exposure to noxious particles or gases. So the most common risk factor is tobacco smoking. But also in some areas of the world, especially women, are exposed to indoor air pollution resulting from the burning of wood and other biomass fuels used for cooking, such as agricultural waste. So why should COPD catch our attention as healthcare professionals? So what is the relevance of COPD? Well, here in Canada, over 2 million Canadians aged over 35 years were living with a diagnosis of COPD in 2012-2013. So this number increased by 82% between 2000, 2001 and 2012, 2013. So maybe you're asking yourself, how come it's increased to that extent? Well, the increase of 82% is being driven by the aging of the population. Regarding the deaths here in Canada, 2 years ago in 2018, chronic lower respiratory diseases were the 5th leading cause of death in the country. So most people, if you ask them what would be the main causes of death in Canada, readily they would think of cancer, heart disease, but they might be surprised that chronic lower respiratory diseases are the 5th leading cause. And in terms of cost to the healthcare system, well, the estimated direct and indirect healthcare costs of 9.5 billion are estimated by 2030. So in the next 10 years, that's what's the cost that's being estimated. And the biggest part of these estimated costs will come from exacerbations, so leading to ER visits and hospitalizations. Now, what are the common symptoms of COPD? So the main one that patients will complain about is shortness of breath or dyspnea. So patients will describe a sensation of air hunger, gasping for air. They'll complain of feeling of heaviness on the chest or chest tightness. On top of that, there's also wheezing, persistent dry cough, production of sputum coming from the chronic inflammation in the airways. And there's also acute exacerbations. So we're talking about deterioration superimposed on stable COPD, and that can include lung infections. A major impact of COPD is limitations for physical activity. So many patients with COPD choose to stop or minimize their physical activities. Why? Because they're afraid of experiencing debilitating breathlessness. And this sensation is caused by dynamic hyperinflation during increased effort. So this hyperinflation leads to increased in FRC, which is the functional residual capacity, which is the amount of air remaining in the lungs at the end of a normal exhalation. So this can lead to gas trapping. And as a result, there's an increase in the inspiratory work of breathing. So what happens during exercise is that the respiratory rate of the patient increases, the expiratory time decreases, and the lungs don't get emptied properly. So this contributes to the patient's perception of his shortness of breath. But there are other physiological factors that can be involved in that process. For example, there are mitochondrial dysfunction, poor muscle oxidative capacity. There's a shift in the fiber type of the muscles from aerobic to anaerobic muscle fiber type. There's also muscle atrophy, leading also to muscle weakness. So often patients, when they're walking or making an effort, an exercise, they will complain of leg fatigue. So all these factors can contribute to the limitation on physical activity. So limitation on physical activity is one reaction that patients have to their breathlessness. Okay, so breathlessness is a fundamentally complex symptom. And what you see here on the slide is a variation of the anxiety dyspnea cycle. It's called the BTF model. So BTF stands for breathing, thinking, and functioning, and it was published in 2017. So as you can see, this model is like a vicious flower, so composed of 3 vicious circles that each have an impact on breathlessness, meaning that it either maintains it or makes it worse. And it's based on three predominant cognitive and behavioral reactions to breathlessness. So breathing, thinking, and functioning. So if we talk about the breathing domain, so patients in reaction to their breathlessness, they will develop dysfunctional breathing patterns. So they will increase their respiratory rate, start using accessory muscles, develop dynamic hyperinflation, leading to an inefficient breathing and increased work of breathing, and this contributes to even more breathlessness. Regarding the thinking domain, so how will many patients react? Well, they will start having thoughts of dying, so develop anxiety thoughts, all this caused by their shortness of breath, so they can start to become hypervigilant and start to anticipate situations where they could be developing a shortness of breath. And that can lead to feelings of panic and making even worse their dyspnea. And in terms of the functioning domain, so we talked about it briefly in a previous slide. So patients will react by reducing their activity level. They will self-isolate, and by reducing their activity, they can become deconditioned, and that leads to even more breathlessness. So all these factors impact on the patient's quality of life. And it's important for us as healthcare professionals to identify which factors are involved in the patient's symptom of breathlessness, so we can design interventions that are properly targeted. Now, what are some challenges that we face as healthcare professionals in helping our patients self-managing their COPD? Well, there are challenges related to the patients, others related to us as healthcare professionals, and other challenges related to the healthcare system. So let's start talking about some of the challenges related to the patient. One important one is lack of adherence to pharmacological treatment plan. So poor adherence to medication in patients with chronic disease, according to the World Health Organization, averages 50% in developed countries. If we talk about pulmonary rehab, for example, the dropout rates are of about 50% within the first 3 to 6 months post-rehab. And if you look at the rates after 12 months, the dropout rates can go anywhere from 55 to 75%. So it's clear that lack of adherence to treatment is a major challenge. Another challenge is patients' health beliefs. Their beliefs about health issues, perceived benefits of action, and barrier to action often explain engagement or lack of engagement in health promotion behavior. So just to give you a few examples, patients may believe that they will have long-term effects from using their bronchodilators. Others will worry about becoming too dependent on their medicines. Some patients believe that exercising can be a threat to their quality of life or even their survival. So these beliefs will definitely interfere with patients' engagement in health promoting behavior. Also, there are difficulties with integrating healthy behavior change. Each aspect of disease adaptation requires behavior change by the patient, such as energy conservation, regular exercise, smoking cessation, and so on. And behavior change is a complex process that involves acquisition of knowledge, of skills, and also self-efficacy. Another challenge is the presence of mild cognitive impairment. There was a publication in 2012 from Villeneuve and al. That mentioned that 36% of COPD patients present mild cognitive impairment. On top of that, there's the anxiety that many patients live with. Some data suggests that up to 40 to 50% of COPD patients experience anxiety and or depression. So that can definitely affect a patient's retention capacity. Other challenges related to the patients is the presence of daily symptoms, such as shortness of breath and fatigue. So obviously having less energy will have an impact on the ability the patient has to focus and to learn to adapt. Also, there are COPD exacerbations. So often in these circumstances, patients have little or no understanding of their symptoms, of the warning signs when they have exacerbation, and of specific actions to be taken. So that can be a major challenge. Also, patients can experience a greater deal of suffering from physical and emotional symptoms, symptoms such as disease complication from chronic hypoxemia. They can have comorbidities such as diabetes, osteoporosis, cardiac, or renal insufficiency. So this can directly prevent patients from carrying out tasks required for successful self-management. And the symptoms that the patient experiences can compound and build off of each other, and this can result in larger negative effect on their daily lives. So all these factors can create situations where the patients have more difficulty learning self-management skills. We can add other challenges such as patients experiencing many losses, such as loss of functional capacity, loss of work. Many patients go through early retirement because of invalidity. This can lead to financial problems. We mentioned earlier also social isolation. So patients reducing their activities involving social outings. And there's impact on all the domains of life, biopsychosocial impacts. And there's also a lot of adaptation required within the family. So it doesn't only impact the patient, but also the family. So family members need to get familiar with the disease. They need to adapt their roles. Sometimes patients, there are things they cannot do anymore. So family members need to pick up on these roles and get more involved. But one of the challenges is that sometimes the family members don't quite understand what is COPD. And often the patient looks well despite having severe symptoms. And this can prevent the involvement of some family members in supporting patient in learning their self-management of their disease. We can also mention caregivers' burden. So many family members experience a lot of stress in supporting or taking care of patients. And it is one of the most important predictors for negative outcomes of a care situation. And finally, we can also mention the stigma that patients with COPD experience, and also guilt, having the impression that they've brought this disease on themselves. So that can be a heavy weight to carry. It can have an impact in reducing patients' self-esteem. So often they suffer in silence. And that also can enhance their dependence on others for care. Now let's talk briefly about challenges related to us as healthcare professionals. So this slide presents some results from a qualitative study that was published in 2015, and it was done in the UK. So that qualitative study explored 14 nurses and allied health professionals' understanding and provision of self-management in clinical practice. So most of them were nurses, but there were 3 physiotherapists and 1 OT. So they asked them questions such as, how well do you think you currently help patients to self-manage their COPD? What do you do to help this? Do you experience any difficulties in doing this? And what came out is really interesting. So a first theme from their answers is that there was confusion amongst healthcare professionals about the nature of self-management. So some of them confused, for example, pulmonary rehab with self-management, okay? One thought that self-management was simply giving information to the patient. One answered that self-management was for the patient to be able to manage themselves without having to speak with a healthcare professional. So, you know, not being clear about the nature of self-management can prevent healthcare professionals to get involved efficiently in supporting patient in that regard. So just to clarify, okay, so what is self-management? It's been defined as day-to-day decisions and activities that patients engage in with the help of loved ones and healthcare professionals to live with and manage their illness. So a self-management program is a support program that involves collaboratively helping patients to acquire the skills needed to carry out disease-specific medical regimens. It involves guiding change in health behavior to help the patient adjust their roles for optimal function, disease control, and to improve well-being. So such a program includes regular assessment of progress, assessment of problems, goal setting, and problem-solving support. Another challenge that we're facing as healthcare professionals is lack of time. So often we need to prioritize other duties. Often we have excessive workload, and sometimes we can feel that we don't have enough time to engage in supporting disease self-management. Another challenge relates to self-efficacy. And we're not talking here about lack of self-efficacy. What came out in that study is that some healthcare professionals may be overconfident as they base current self-management practices upon knowledge and skill developed through practices and experience rather than on formal training. So being overconfident, most are not aware of their educational needs to improve their ability to support proper patient self-management. And finally, an interesting finding is that some of us as healthcare professionals may have assumptions related to patients' ability to self-manage. So in that study, 5 participants felt, for example, that older patients prefer to defer responsibility for managing their condition to the professional, and that they prefer the social interaction offered by regular visits to healthcare services. Also, self-management was believed to be culturally less acceptable to patients from ethnic minority backgrounds, but the participants did not specify what those barriers entailed. Also, it came out that some believed that older patients were less confident, unmotivated, and having greater potential for cognitive deficits that could impede self-management. So if we have these assumptions as healthcare professionals, again, it's clear that it can be a barrier for us to support efficiently patients in learning to self-manage their COPD. So the conclusions from the author is that healthcare professionals were ill-equipped to support self-management. So this can be addressed by having clearer guidance for the implementation of self-management in COPD. So we'll get to that later about having clear guidance. Okay, are there resources available to help us in that regard? So we'll talk about this later in the presentation. And finally, there are challenges related to the system. For instance, accessibility and availability of services is not always easy. So patients sometimes encounter difficulties in seeking a timely physician appointment. There are delays in consultation. Patients may have difficulty to access a prescription in case of exacerbation. Also, some patients feel that convenient access to a healthcare professional is often limited, and no one is readily available to clarify small questions as well as urgent concerns. Some patients also mentioned that there's confusing information provided by different healthcare professionals that can raise issues related to knowledge about self-management. Also, sometimes we experience that we lack privacy. We don't have the proper room to be alone with the patient and to engage in proper self-management education. So these are some challenges that we face. And another challenge is the lack of continuity of care. So for example, patients can enter the system through the emergency. When they get discharged, then there's a lack of communication or liaison and follow-up with family doctors, specialists, or case manager. And that is if the patient does have a family doctor, specialist, or a case manager. So now let's get to the second section of the presentation. How can we improve symptoms management? So bronchodilators form the mainstay of pharmacological therapy for COPD. So as you can see on this slide, it's been shown that bronchodilators bring about a lot of benefits. They decrease airway smooth muscle tone, which leads to improvement in expiratory flow rates, reduction in hyperinflation, which also leads to reduction in dyspnea, improvement in exercise tolerance, and in health status. On top of that, bronchodilators can contribute to reduce frequency and severity of exacerbation. So this highlights or puts the emphasis on the importance of patients to take their medications, their bronchodilators regularly so they can enjoy these benefits. Another pillar of COPD management or symptom management is physical activity or exercise program. So again, as you can see on this slide, there are many benefits. We can say that exercise is probably the single most important treatment in COPD. It improves functional capacity in activities of daily living. It enhances quality of life of the patients, and it's been linked to the reduction in healthcare use. So if we look at the slide, so studies have shown that physical activity can improve aerobic endurance, improve muscle oxidative capacity, also reduce anxiety and depression. It's been shown to improve maximal and submaximal exercise, worse capacity, reduce heart rate and ventilation at submaximal workload. And interestingly, it's been shown to improve spine mobility, which can reduce the work of breathing. And as a result, there's reduction in dyspnea for a given submaximal effort. Now, if we focus on this specific benefit, so there was a study more than 20 years ago published in 1998 from O'Donnell and al. So what they did, they had COPD patients participate in a six weeks of exercise program. So 3 times a week, patient went through multimodal leg and arm endurance exercise. And what came out of this, if you look in the middle column, the DH, so after the 6 weeks of exercises, it's been shown that there was a decrease in dynamic hyperinflation, which resulted in a decrease in dyspnea experienced by the patient. So it's just to show one way that there's a reduction in dyspnea through regular physical activity. So bronchodilators, exercises are effective components of symptom management, but more is needed. And that's what's shown on this slide. So it's describing global management of COPD symptom. So if you look at this table 5 here, that was published already in the CTS recommendation for the management of COPD in 2007. So for patients with mild COPD, so we're talking about patients with MRC of 2 out of 5, so meaning that patients get short of breath when they hurry on the level or when they go up a hill. So the components of that management of symptoms involve 5 elements. So first of all, education and smoking cessation programs to prevent disease progression. Second, prevention of exacerbation through proper vaccination to reduce frequency and severity of exacerbations. Third, initiation of bronchodilator therapy to alleviate breathlessness. Fourth, encouragement of regular activity to improve exercise tolerance and daily activities. And also, the last one, they recommended close follow-up and disease monitoring. So all these to contribute to improve the health status of the patient. But more is needed as the disease progresses. So when patients have moderate or severe COPD, more is needed. So we did talk about education, but education alone is not associated with improved lung function or exercise performance, okay? So what is needed? What should be added? So if you look at table 6, okay, so components of a patient education program in COPD. So again, education on smoking cessation, basic information on pathophysiology of COPD and rationale for medical treatment, education on proper inhalation technique of the devices, and self-management with case manager participation. So that's very an important point, okay? So we mentioned that education alone is not sufficient, but when you add this with the presence and the participation of case managers, so this leads to better outcomes. So the case manager will perform initial and follow-up evaluation, so biopsychosocial evaluation. The case manager plays the role of the educator to facilitate integration of self-management strategies. He plays the role of the resource person, the go-to healthcare professional that can be easily reached by the patient and the family. The case manager is also in charge of the coordination of the patient's care within the interdisciplinary team. He can refer the patient to other healthcare professionals when needed. So that support of the case manager will really facilitate patients' integration of self-management strategies. Other components of a proper, adequate patient education program involves also early recognition and treatment of acute exacerbation of COPD, strategies to alleviate dyspnea. It's important also to evaluate the readiness of patient in addressing advanced care planning issues, okay, or end-of-life issues. So just by example, telling the patient, you know, many patients have concerns about how things will go as the disease progresses, okay? Either in terms of treatment or decisions they have to make. Is that a concern for you? And according to the response of the patient, then we can decide to what extent we can continue to address that issue. So evaluating the readiness of the patient in that regard is very important. And the last point in that table was identification of educational resources. And again, we'll get to that in the next slide. So these components need to be individualized as they will vary with disease severity and patient's need. Okay? Now, we talked about identifying educational resources. So one of these resources that you probably are familiar with is the Living Well with COPD website, okay? And this is just an example of what can be found in one of the modules of this website. This is a slide presenting the Living Well with COPD module entitled Managing Your Breathing and Saving Your Energy. So in this model, we found these three elements. So there's coughing techniques, so controlled coughing technique and huffing technique. They present the active cycle of breathing, and there's a link with a YouTube video. And there's also a section on OPEP devices, so oscillating positive expiratory pressure devices, okay? So the Living Well with COPD website is an excellent resource for healthcare professionals and patients in helping with self-management strategies integration. Another example is about relaxation techniques. So on the website, there are learning activities and PDF documents on diaphragmatic breathing, visualization techniques such as the stop negative thoughts and the positive thinking. So these can be shown on the screen or printed for the patient to help support integration of these strategies. Now, another important resource associated with the Living Well with COPD website is the action plan. And it's interesting because the written action plan can be a global strategy to summarize the education. So the action plan is a plan of life that involves the integration of many self-management strategies such as taking inhalers regularly, breathing control, energy conservation, anxiety control, and so on. So this action plan, if well integrated, can allow patients to prevent aggravation of symptoms or to know how to deal with aggravation of symptoms when they occur. A correct utilization of the action plan can allow the patient to become more autonomous and to initiate a treatment at home. And this can lead to prevention of ER visits and hospitalizations. But the integration of the action plan for the patient is a long process that requires patience and many different experiences from the patient. Just to highlight, integration of the action plan involves goal selection, information or data collection, interpretation of that data, and then proper decision making, action, and also self-efficacy. So as healthcare professionals, we play a major role in guiding the patient in learning about integrating the proper use of the action plan. And the Living Well with COPD website is a useful resource in that regard. Now, let's get at section 3 and talk about successful interventions. So proven interventions in COPD symptom management. But before we get to that, let's talk about advice giving. So often, because we lack of time, because we want to make sure that we're having this impression we're doing a good job, the easy way to go is to quickly give patients advice. You should quit smoking, you should take your medication regularly, and so on and so on. But what are some problems with simply giving advices to patients? Often, healthcare professionals don't consider the patient's level of motivation for change when they give an advice. It's also important to remember that adults need to play an active role in their learning processes. We don't like to have anything be imposed on us. So sometimes patients may have that impression when we're just giving advices that we're trying to impose on them. Also, in order for change to occur, patients need to be aware that there's a problem. It has to be clear for the patient how his own behavior contributes to his problem. And also the patient needs to believe that change is both beneficial and possible. And another issue with advice giving is that sometimes our arguments for change are not relevant to the patient. So if the patient doesn't see the practical value of our advice, he won't be interested and he may tune out mentally. And also, this approach can lead to defensiveness and resistance from the part of the patient. So given these problems, what approach should we have? What criteria are involved in behavior change, and we should take these into consideration? Well, first of all, knowledge in order to raise patients' awareness, but that's not enough. We need to take into consideration the motivation level of the patient. And, is what we're proposing, is it important to the patient? Is the patient believing that they will benefit from, integrating such and such healthy behavior? And do they feel that they can do it, okay? They have the ability and that they will get benefits. So we're talking about the self-efficacy here. Now, taking these elements into account, so we'll talk about a study that was done with the Living Well with COPD program that was developed and tested in 1998 in a large randomized clinical trial. So what they did is that they evaluated the effect of a continuum of self-management specific to COPD on the use of hospital services and health status among patients with moderate to severe disease. And there was a usual care group that was compared to the intervention group. So what was involved with the intervention? So the patients in the self-management group received education intervention in the form of a self-management program that consisted of 7 to 8 one-hour weekly sessions with a case manager. So it's important to highlight that there was a case manager that was involved and available. They had a workbook and a customized prescription for exacerbation, so antibiotics and prednisone. And they also received advice on a simple home exercise program. And the follow-up consisted of monthly telephone assessment during the first year only, so over 12 months. So what was found? So it was demonstrated that the Living Well with COPD program, when implemented under the supervision of a healthcare professional, it can improve individuals' quality of life and reduce hospitalizations and emergency room visits by 40%, and also reducing unscheduled medical visits by 60%. So in order to achieve this, the Living Well with COPD program, combined with regular follow-up by a case manager, demonstrated to be successful to support COPD patients in taking charge of their health by integrating healthy behaviors and skills to self-manage their illness on a day-to-day basis. But these were really amazing results. Other results were regarding improvement in quality of life. So at 4 months, there was a difference of 4.2 in the health-related quality of life scores as determined by the St. George's Respiratory Questionnaire. So it is not only statistically significant, but also clinically significant. And the impact score difference almost reached statistical significance at 12 months. So these differences at 4 and 12 months reached the minimal clinical important difference of -4. But now one can ask, are these benefits sustained over time? So there was a study that looked at this question, okay? So that's, if you look at the screen on the slide, so they just continue to record ER visits and all-cause hospitalization. And what came out is that compared to the standard care group, the intervention group had significantly fewer all-cause hospitalization at both 1 and 2 years. So if we look at the second year, so there was a reduction of almost 27% in all-cause hospitalization. It was also noticed that emergency room visits were significantly reduced. So the authors concluded that the sustained benefits of this type of self-management education mean that this approach should be part of a standard care for COPD patients, especially those with impaired health and frequent exacerbations. So it's interesting to see that even after the end of the first year of the study, even after the intervention, there were positive results that were maintained. So if we talk a little bit about the Living Well with COPD website, okay? So we introduced this a bit earlier in the presentation, but it's an amazing resource available for us as healthcare professionals and also for patients. So there are online learning courses that are available. So maybe most of you are more familiar with the modules, but actually there are online courses, okay? And an example is session 1, preventing your COPD symptoms. And there's learning video that lasts about 12 minutes that's available on regarding that topic. Other resources, like I mentioned, there are modules. There are about 10 modules about each healthy behavior that patients are encouraged to integrate. There are also other learning activities, okay? So an example here is how to remove sputum from my lungs, okay? So there are information that are given to the patients on that regard, but also on other topics. So sometimes when we have our patients in our office, we can go directly on the website and show patients how they can benefit from these resources. Now, another question that we can ask ourselves is, patients with more severe COPD, with a heavy burden, can they also learn to integrate self-management strategies? So that's a study that we did here at the Montreal Chest Institute. So we looked at patients with severe COPD exacerbations. And this study was a real-life situation aiming to assess whether or not it's possible for COPD patients with high burden of disease to self-manage acute exacerbations and to reduce hospital use. So what we did is a chart review of 100 randomly selected patients' charts. And we had 2 cohorts. So one cohort of patients that were followed in 2006, and another cohort that was followed 3 years later in 2009 at the MCI clinic. So if we look at the tables on the next slide, so within 3 years, we see that the clientele became more severe. If you look at the FEV1, although it was not statistically significant, in 2009, in average, the FEV1 was 0.85 liters compared to 0.98. But in terms of exacerbations, that was statistically significant with a p-value of 0.03. So in 2009, patients experienced 160 exacerbations compared to 126 in 2006. So that's like 1 exacerbation per year extra per patient. So 3.6 exacerbations per year per patient in 2009 compared to 2.6 in 2006. And what came out is that although they had more severe disease, so with more exacerbations, the second cohort in 2009, patients had more appropriate self-management behaviors, defined as, for example, a call to the case manager if they have new symptoms of worsening, or starting their prescribed treatment, the prescription of antibiotic and or prednisone. Also, it's not shown on the slide here, but in table 3 of the article, it was shown that there were more phone calls to the case manager. So we're not talking about phone calls only in the context of an exacerbation, but overall. So 590 phone calls in the second cohort compared to 382. And also it was shown that the second cohort had fewer physician office visits. So what was the conclusion? So this study showed that a more severe COPD patient population can be taught self-management skills in the event of exacerbations, and this leads to fewer healthcare visits and hospitalization admissions. Now, all this is very interesting, but like we mentioned earlier, we're facing different challenges as healthcare professionals in getting involved in supporting patient self-management education. So how can we engage in that when maybe we're lacking time? So this is a case scenario vaguely inspired by a real case situation. So a day at the clinic. So Mrs. Cope is a 67-year-old patient. She suffers from COPD. She lives alone with her dog. Her dyspnea on the modified MRC scale is 3 out of 4. Her FEV1 is 0.66, and her ratio is 40%. She's on tiotropium daily, and the combination of fluticasone and salmeterol, 2 puffs BID, and she's on salbutamol PRN. So since her last appointment 4 months ago, she's used 3 courses of prednisone without notifying any healthcare professional. So the doctor brings her to your office to meet with you for the first time and says, well, this patient is not well controlled despite having optimal therapy. She told me she forgets doses of her inhalers. I will not renew any prednisone course for now. And cherry on the cake, patient tells you, my paratransit transport will arrive in 15 minutes. So that's a big challenge. How do we deal with that? So already we see that there are a few issues, okay? Why is the patient taking so many prednisone courses? Is it really because she's having recurrent exacerbations, or is she simply having an inadequate use of her prednisone prescription? Is she refusing maybe to go to the ER when she's not well because she doesn't want to leave her dog alone at home? Why isn't she calling any healthcare professional when she's having worsening of symptoms? We also see the issue of the lack of adherence to the inhaler treatment. So obviously we cannot address all these issues in less than 15 minutes. So we need to prioritize one and address it. So here's a suggestion. It doesn't mean that's the only way to go about it, but it's a suggestion. So first thing is to determine collaboratively with the patient the goal of this brief session. So for example, we can say, I'd like to discuss how you're doing since your last visit and see if there's anything else we could be doing for you. Would that be okay? So that way we're, sorry, we're setting the agenda and we're asking the patient permission. So that way we don't impose. Then the next step is to attempt to share information with the patient. So we can say, despite being on optimal medication, you haven't felt that your shortness of breath was under control to the point that you decided to use your prednisone prescriptions a few times. What do you make of that? So we're using an open-ended question, and we're attempting to raise the patient's awareness on how her own behavior may contribute to her problems. Then we can ask another open-ended question. How would you like things to be different? So that way, we can help the patient perceive a discrepancy between her present behavior and important personal goals and values. And we know that change is motivated by that perceived discrepancy. And then we can ask the following question. Maybe we're not doing everything we can to help you control your symptoms. Would it be okay if we reviewed one of those strategies together? Maybe we missed something, okay? So once again, we're not imposing, we're asking the patient permission. And where we can ask also at the end, can I tell you how each medication works and why they are both important? So that's a way to gradually offer the patient sharing of some information without forcing it, without imposing. Just a little thing about the question, how would you like things to be different? When we're asking that question, we're also allowing the patient to think about positive outcomes that are important to her. Now, patient may be having different barriers that prevent her from taking her inhalers regularly or using her prednisone prescription regularly. Patient may be concerned about possible side effects from her inhalers. Simply, she could be forgetting and so on. So we need to address that. So how can we go about that? So overcoming ambivalence about change. So again, using properly open-ended questions to explore motivation. So we can ask, what do you see as the potential advantages of having fewer symptoms, less shortness of breath, less mucus, and less coughing? So previously, we explained to the patient the role of the inhalers and the benefits that she can get out of it. So now, once this is done, then we ask her about potential advantages of having fewer symptoms. What would it change in your daily activities if you had fewer symptoms? So that way we can allow patient to express some change talk, to present arguments for change. And then we can ask, what would have to happen for you to consider taking this daily medication? So again, this allows the patient to present some ingredients of a personal recipe for change. And from the answer that we're getting from the patient, in collaboration with her, we can try to look at some possible solutions to help her take her medication regularly. Now, self-efficacy, as we mentioned earlier, is an important element involved in behavior change. So this can be addressed the following way, using a 10-point scale to explore confidence. So we can say, well, let me ask you something else. On a 0 to 10 scale, where 0 is not at all confident and 10 is extremely confident, how confident would you say you are in your ability to take your inhalers as prescribed? What will have to happen for you to go, for example, from a 2 to a 6? So that's if the patient gives a low score, okay? What will have to happen for you to feel more confident or less anxious about taking your inhalers regularly? So from the answer of the patient, then we can work at raising her level of self-efficacy, either through verbal persuasion, relating to past positive experience she had with using medication regularly, and so on. So after that, we can brainstorm solutions with the patient, agree on an intervention plan, agree on a follow-up plan, because there are other issues that need to be addressed also, maybe later over the phone or on an upcoming clinic follow-up. You can briefly refer the patient to the Living Well with COPD website by giving the little cards or the little pamphlets. And before the patient leaves, you can ask the patient to briefly summarize what has been discussed in the last 10 to 15 minutes. So you can say, well, can you just summarize in 1 or 2 brief sentences what did you get out of our meeting today? Okay, just to emphasize the main points. So what has been achieved in 10 to 15 minutes? Well, you've used motivational communication, you've evaluated self-efficacy, you've shared valuable information with the person, and also you've been able to do a summary at the end. Now, talking about summary, let's summarize our presentation for today. So what did we discuss? Well, we started off by talking about the prevalence of COPD, which is continuing to increase. And we mentioned that exacerbations account for the greatest COPD-related costs. Also, we mentioned that symptom self-management is key to lowering these costs and improving the quality of life of your patients. But there are many challenges that exist for healthcare professionals when supporting their COPD patients in dealing with their symptoms. There are challenges related to the patients, other related to us, and challenges related to the healthcare system. And we need to identify them so we can try to work around these barriers. And finally, we looked at a way to support patient self-management when we lack time using the Living Well with COPD resource, the website. But also we talked about using open-ended questions to ask permission for sharing information, to explore motivation, to explore patients' confidence. And that can help us overcome some of these challenges. So this whole process has to be done in a spirit of collaboration with the patient. Now, another resource, just to finish our presentation, that can be really helpful for us as healthcare professionals is the Expand platform. So on this platform, there are courses available for healthcare professionals. Two of the courses are COPD management for healthcare professionals and proper use of inhaled medication. So to access these courses, you need to create a free account. You can do this today at expandcourses.com. So these courses can benefit healthcare professionals, exercise professionals, so physiotherapists, kinesiologists, and also patients, family, and friends. Where can you find the courses? So there's a tab, a courses tab, where you can go to see all of the available learning courses for the healthcare professionals. So just a brief description of the two courses. So COPD management for healthcare professionals, there are 3 modules. First one is on the pathophysiology and treatment of COPD. The second one is management of COPD symptoms. And finally, integrating a plan of action for life. So this course includes patient testimonials, exciting videos, and a comprehensive case study. And you can get 0.7 continuing education credits for it. The second course, proper use of inhaled medication. So it includes also information on how to use properly the different devices and their mechanisms. There are instructional videos and patient interviews. And you can also get 2 hours of learning at the station. So finally, you can also access on the website webinars, such as today's webinar. So you go on the webinar section and you can replay the recordings of our past free webinar. So the Living Well with COPD website, as well as the Expand website, are 2 excellent resources that can support us in helping our patients in learning how to self-manage efficiently their COPD. So thank you very much for your presence, for listening. And just to finish with some acknowledgements, so we'd like to thank Maria Sedeno, Dr. Bourbeau, and Emily Horvat in the development of this webinar. Thank you very much.
Thank you so much, Alex, for a very comprehensive presentation for symptom management in COPD. I really love the examples of the actually the real life scenarios at the Montreal Chest Institute Clinic. I just want to read some of the questions that came during your presentation. So a couple of people are asking if we're going to get a copy of the presentations. In fact, we will, like by registering to expandcourses.com, you can get the replay of the webinar as well as the PowerPoints. Then the other question is, why does exercise decrease hyperinflation? It's one of the first questions that we have here.
Okay, so that's a good question. There are many research that were done on that topic. So, you know, when patients exercise, also they need to learn how to control their breathing. Okay, so patients can learn the pursed lip breathing technique. They also learn with the physiotherapist how to pace themselves. There's also a training of the large muscles, the quads, for example, in the legs. So the muscles become more efficient in using efficiently the oxygen. So, and patients also, they need to learn how to use their inhalers before exercising. So all of this can help the patient to reduce the hyperinflation. So for example, by using the pursed lip breathing during exercise, they learn to breathe out for a longer period of time, to exhale longer, to empty their lungs. So there's more space for new air to come in. So that can help the patient breathe better and reduce their sensation of dyspnea.
Perfect. I don't see any other questions here. So in respect of the time, I just want to thank everyone again for coming today to the sponsor. And in a couple of days, this presentation will be available on the website as discussed. Thank you, everyone. Thank you so much, Alex.
It was a pleasure. Thank you.
Thank you so much.